All right, so on 286, there's the video on psych endocrine session number 6. And these Google Doc notes are what I was mentioning earlier. When you go on the Google Doc notes, you will see it starts with psych. Scroll down, scroll down, scroll down, and you start in with endocrine. And here's endocrine here. All right, so endocrine is going to have diabetes included in it, where I break down the definitions around diabetes. SIADH, that's a very good one to know the difference between diabetes insipidus and SIADH. So those two are here. And then we go with some notes there on how to keep up with them and which assessment findings and lab findings are associated with those.
Mhm.
All right. And then you have diabetes insipidus, the image here. And then I start talking about type 1 diabetes versus type 2 diabetes. So, type 1, I talk about the three polys. And then I talk about type 2, where we go through the three polys again and the differences between type 1 and type 2, and then the treatment for type 2. It's going to be a little bit different than type 1. All right, I talk about the importance of diet in a patient who has a type 2 diabetes. And then we go into the insulins, their peak times. All right, so regular is mentioned here with its onset and peak times. NPH is mentioned here with its onset, peak time, and duration. All right, and I mentioned the peak time 6 to 10 being somewhere roughly between the onset of 4 hours and the duration of 12 hours. And I also mentioned the cloudy suspensions and all the things about that, and the reason why you cannot give NPH IV. Then there's Lispro, all right, the fastest acting. I talk about the onset, 15 minutes, and the peak time for that. And then the longest acting one, glargine, and we talk about how long that lasts and how what. And I give you a couple of ways to remember how to keep up with those with some different nursing clues. All right, and then exercise, the importance of exercise and what it does, and then how a person who is sick, when a diabetic is sick, how the glucose goes up, all right, on its own, even if they're not eating. And then we finish up this one with the complications of diabetes, including hypoglycemia, and how that's a complication related to too much insulin or not enough food, and the signs and symptoms of those, which make a person look like they're drunk and in shock, and then all of the symptoms I mentioned here, along with the shock and the symptoms that are associated with being drunk, okay, and the words that are used there, and then how to treat it, right? Juice, pop, regular candy, um, and then some other ways you might treat that, including glucagon, IV dextrose, and how that might go. All right. And another complication of diabetes is type 1 hyperglycemia, which is DKA. Remember, DKA only really happens to type 1s, whereas I also have here that other complication of HHNK, right, that we mentioned before, hyperglycemic hyperosmolar non-ketotic syndrome, which is essentially dehydration. For the HHNKs, it's only in the type 2 diabetics. So type 2s don't get the same treatment when they develop hyperglycemia as the type 1s. Type 1s get human regular insulin, as you have mentioned, but type 2s get fluids because it's basically just dehydration for them. They don't necessarily get a big bag of regular insulin. They get fluids, fluids, fluids. So I think you got those questions correct. All right. And then I talk about long term complications like the HbA1c being elevated, poor tissue perfusion, peripheral neuropathy. Those are long term problems associated with diabetes. So when you think of these problems, you will know this is why diabetes shows up on the NCLEX over and over again, because there's so many people who suffer from diabetes, and B, when they do, it's very life threatening if they go through DKA, or it's also life threatening when they experience hypoglycemia. So as a nurse, you have to know you have to know the difference between the two. And for the NCLEX, they really want to see that you know the signs and symptoms that are associated with each so you don't confuse them with one another. All right, so that's a worthwhile lecture. And then I start in with the thyroid. All right, we talk thyroid and what that means and how it's different from the issues that people connect with hypoglycemia sometimes. And then we talk thyroid storm is in there, very important, emerging crisis. After thyroid, hyperthyroid, and then hypothyroid. It's just like glycemic or hyper and hypoglycemia. Knowing the differences between the two, NCLEX wants to see that you know the difference between the two. So hypothyroid versus hyper. Adrenal cortex, those where we get the steroids. And you notice the steroids keep coming up. So you definitely have to know what all the drugs that end in "sone," those are artificial steroids, but it's also good to know the glucocorticosteroids. Those are the ones that are naturally occurring and that get fired off by our little adrenal cortex, those two little pyramid shaped glands that sit on top of the kidneys. Okay, so definitely want to know the adrenal gland disease because that's where you get Addison's disease, which NCLEX loves Addison's and Cushing's. So knowing the difference between Addison's and Cushing's, one is hypo um, production of the steroids, and the other one is hyper secretion of the glucocorticosteroids. So knowing the difference between Cushing's and Addison's are explained in that video as well. So the endocrine, if you want to look at my video, it's kind of long, so you can fast forward your way through it as you need the different topics. But I'm just following along with these notes here to help you have an understanding of those endocrine disorders that show up over and over and over again on the NCLEX. And this gentleman and lady both have Cushing, so I do try to describe what that looks like and how you can tell the difference between the two. All right. It's worth your trouble to look at endocrine diseases again because NCLEX really loves those. All right. So I'm going to go back over to finish up looking at the questions that we had now that we know where you can see that again. And I'm just going to finish off with the ones we went through. Okay, so administer regular insulin IV as the priority action in a person with DKA. All right, here's our next one. We got the guy with type 2 diabetes, and they have the blood sugar 120, temperature 101, pulse 88, respirations 22, and blood pressure 140 over 84. Which one is the most concerning? In a diabetic, it's going to be temperature because an elevated temperature in a diabetic means infection, and infection will cause an episode, a trigger for diabetic ketoacidosis or the HHNK, because an infection will trigger the fight or flight stress response, and that would cause the patient to blood sugar to go up. Okay, so any sick patient is going to have elevated blood sugar. That's why we walk around the hospital taking everybody's blood sugars, because all of them, even the non-diabetics, are experiencing hyperglycemia because they are ill and because they're in the hospital. Okay, so when a person gets an infection, works the same way. They're going to have elevated blood sugar. It's one of the ways. It's really a tricky thing about those diabetics. When they are diabetics, they are more likely to have more accidents, infections. They are more likely to bruise when they like hit a part of their body against something, and their bruising will then lead to an infection. Okay, so it is important to keep your eyes out for that on the NCLEX. It's a very LPN thing too, for NCLEX to want to know how you're trying to prevent your client from having a worsening condition. So, like promoting their health and making sure that they stay free from infection or stay free from worsening harm. Okay, so that's what this question's getting at. Okay, so temperature, that's the one that's a little off, but that's the one you want to be concerned about. Blood sugar, that's expected. The respirations, not too bad. It's only 2 beats per minute over. And it's not like you have any other signs and symptoms. Now, if the respirations were like that in a patient with asthma, for example, you might want to come in and pay more attention to that. But because it's a diabetic, we always want to keep them from getting an infection. All right, question number 18. This is the question about the inadequate understanding of how peak action works in NPH. So, notice that with a question where they're asking you, it's a negative inquiry question, meaning they want to know which of the answer choices is incorrect. Whenever they're asking you which one is incorrect, usually you can look at 2 or 3 of the answers and say, hey, those are correct. Those are the same as one another. So notice that the best time for me to exercise is right after I eat. This is the same thing. C option, the best time for me to exercise is after breakfast. D is the same thing. The best time for me to exercise is after my morning snack. So each of these are the same because they're all saying that it's actually safer for a patient with type 1 diabetes to exercise after they eat because the blood sugar will be high at that moment or higher than normal. And then they won't slip into recurrent episodes of hypoglycemia with exercise. Okay, so the worst thing for them to do is to exercise afternoon, and it doesn't mention anything about the eating and where they're eating. So say you exercise in the afternoon every time, but you haven't eaten yet. So exercise plus not eating will cause hypoglycemia because exercise by itself will raise the insulin levels and bring down the blood sugar. That's why we want type 2 diabetics to exercise more because that will help control their blood sugar. Okay. But, it's a balance. And when you're a nurse looking out for a patient who has diabetes, you're trying to strike a balance between normal, what's too high and what's too low. You want to get normal because if you get too low, they could pass out, have a coma. That's very dangerous. If it's too high, they can get DKA. They can go blind. They can lose the feeling in their fingers and toes. I mean, hyperglycemia, everything that goes along with it. Okay, so remember that. A type 1, you want them to exercise after they eat, especially if they've been complaining of recurrent episodes of low blood sugar whenever they exercise. Okay, does that make sense?
Yes.
Okay, good. Okay, good. Going on to 19. Hopefully, I can get through all of them. Okay, so here we go. The client with diabetes visits a healthcare clinic. And so even though they had diabetes that was well controlled before, recently they had high blood sugar that was running 180 to 200. So they're wanting to know which medication may have contributed to this episodes of hyperglycemia. Well, we have to go with the steroid. Why? Because glucocorticosteroids raise blood sugar levels. All right. Think about your Cushing's disease patients. Because they have too many glucocorticosteroids in their blood, sometimes they look a little elevated in their fat and they have those hunches on their backs, fat face. It's like high blood sugar. Okay. So folks on steroids are going to get bigger. They're going to get more glucose in the blood. So they will need more insulin, more help with controlling that. Maybe they even get some more metformin. Okay. So that's steroids. NCLEX likes that question. They always like to introduce a steroid, a SON, right? They like to give you some information about that, and then they want to know what you're going to do with that. Okay, diabetes plus a steroid is bad. Always see that. Well, not bad, but sometimes there's nothing you can do about it. A patient who happens to be a diabetic also has a need for a steroid for some other reason. All right. Well, all you do is watch it, pay attention to it, and give the patient more insulin. That's the treatment for that. All right, next one. Glucose is an important molecule in a cell because what does it do? It gets the energy. That's why when a person doesn't have enough glucose, they will be sluggish. They will be confused. All right, they will have a low energy. okay, a level. So glucose is, that's the building blocks, not the building blocks, that glucose is like the fuel we need to go. It gives us our gas, right? So when we don't have a good glucose insulin relationship like in diabetics, sometimes you'll see that those folks, they spend more time in a confused state when they're hypoglycemic, because so glucose gives us our energy. It gives us our fuel to keep going. All right. Number 21. We talked about this. A patient with HHNS or HHNK, usually a type 2 diabetic, because the type 1s get DKA, but they are the same thing essentially. Too high a blood sugar. What do they both need? Fluids. They both need fluids, but the priority for the DKA is insulin. We've already determined that. So never forget that. A DKA person, the priority is insulin plus fluids, right? They'll usually get insulin in a Y bag along with fluids. Not your problem, because you won't be tested on IV drugs, but it is still good to know. All right. And fluids, that's what we're going to do for the patient with HHNK. All right, the three correct answers here are palpitations, diaphoresis, slurred speech. We already talked about that. Client experiencing DKA, the insulin that would be administered is human regular insulin. We never give NPH to a patient who has a need for IV insulin. Okay, it just won't work. NPH is cloudy. That's the cloudy one. Regular is the clear one. So never give anything in an IV bag that's cloudy. All right. And I know you're not giving IV medications. So I don't want you to spend too much time on that. Okay. Number 24, the nurse recognizes that additional teaching is necessary when the client who is learning alternative site testing for glucose monitoring says the following. So, in other words, which one is wrong? Oh, I've got another unstable connection. I hope I keep you here in the last couple of minutes. All right, the correct answer is the fingertip. I think I heard you say something about the fingertip. All right. Um,
Mm.
so they're saying additional teaching is necessary because the fingertip is for hypoglycemia. If you suspect hypoglycemia, the fingertip is better for that. When it's hyperglycemia, you might want to use other sites of the body other than the fingertip. Okay. So,
So hypo is the fingertip.
yes, when you're going to look to see if somebody
Hyper.
is having DKA or hyperglycemia, any other site might be helpful to know. Okay.
Mm.
So alternative sites might include other, the, um, actually just drawing blood, drawing the patient's blood and testing that for blood sugar testing. Okay. Now, here's the last one, and you see how many correct answers they had there. They had A, B, C, D, E, F, and then H. All right, let's look at all these signs as signs of hyperglycemia or diabetic ketoacidosis, really high blood sugar. Fruity odor breath. Yes, you're going to have a fruity odor to the breath when a patient's in DKA. Absolutely. They'll say also that it smells like acetone breath, and they'll also say that it smells like fruit, that chewing gum called juicy fruit chewing gum. I've never smelled that juicy fruit smell, but I have smelled this like weird smell. But that's when the blood sugar is so high. Okay. Deep and labored respirations. And those are Kussmaul's breaths that go along with being in acidosis. So remember, ketoacidosis is a metabolic acidosis. So the patient will experience things that patients in metabolic acidosis will experience, like Kussmaul's breathing, which is deep and labored respirations. Blurred vision. Yes, blurred vision goes with hyperglycemia. Because the blood sugar is so high, you're dehydrated. Those are blurred vision symptoms. Increased urination, yes, because remember polydipsia, polyuria, and polyphagia. All right, increased urination is polyuria. Okay, just another word for polyuria. Increased thirst is polydipsia. Right, you're going to keep going back to have more and more to drink because you cannot quench your thirst. All right, so increased urination, increased thirst, definitely in there. Fatigue, yes. Fatigue in a patient who has hyperglycemia because they can't get the energy from all of the glucose because it's trapped in the bloodstream. It can't get into the cells where they can help us gain energy through our cells. Okay, so the patient will be tired, they will be fatigued, they just can't get it together. And then finally, dehydration. Whenever a patient is hyperglycemic, they are also dehydrated. And I like to think of it as all those crystals of sugar are filling up the bloodstream and that you can't get any water in there. Okay. There's not enough water in there and it's just making the person thirsty and it's making them urinate a lot. And so they're dehydrated. That's the main reason why they're dehydrated because they're increased urination, increased thirst. Okay. What they are not is hypoglycemic because the blood sugar is too low here to be DKA. All right. The respiratory rate can't be 8 beats per minute, which is hypoventilation. And then they also have deep and labored respirations. You can't have both. And then hypernatremia, it's just not related. It just has nothing to do with this. And NCLEX sometimes likes to throw in those extra conditions that aren't related. And then finally, he's not in metabolic alkalosis. DKA is acidosis. Okay, so they're in metabolic acidosis. All right, did that make sense?